and today I want to go more into detail about subluxation. To start off with, I want to talk about some definitions and symptoms of subluxation. Some definition is partial or incomplete dislocation. The mechanical integrity is declined, and the humeral head slips out of that glenoid cavity, which can result from weakness in that rotator cuff. Some symptoms you might see with subluxation is constant pain, which we learned in class is debatable if pain is correlated with subluxation or not. But you might have dull or stabbing pain in that shoulder, popping or grinding with that shoulder movement. You'll definitely have a decreased range of motion and muscle weakness. However, some people may notice little or no symptoms at all. Some causes of subluxation is muscle imbalance, that loss of ligament support in the rotator cuff. A lot of CVAs, you'll see poor trunk, neck, spine, and pelvic alignment that can also cause subluxation. And then loss of scapular orientation on that rib cage and repeated stress to shoulder. So it may not happen right away, but if they keep getting the stress on the shoulder, that could also cause subluxation. And then you can see subluxation also in trauma like sports. How to measure subluxation. There's a 3-point scale used, 0 meaning no subluxation, 1 meaning minimal, and 2 meaning substantial. With that, you can use a finger test. We learned in class, if you can put one finger in the space of your shoulder, that could be minimal subluxation. If you can fit 2 fingers, substantial subluxation. So in this picture, you can see in his shoulder that he has subluxation. You can also see on his left side where he doesn't have that subluxation, he has greater muscle tone, and even on the right with his subluxation, he has weak muscle tone and he keeps that arm closer to his body than his left side. With subluxation, there are 3 patterns that you can see in patients. The most common is inferior subluxation. However, to determine the 3 pattern of subluxation, the therapist needs to assess trunk posture, the position of the scapula. Also, the therapist needs to evaluate the mobility of the scapula and examine the mobility and alignment of the glenohumeral joint. So a lot goes into subluxation. The first subluxation is inferior. So that's when the head of the humerus is below that fossa. And with that, you can see flexion to the weak side with trunk alignment. With your humeral alignment, you can see abduction and internal rotation. And then the movement ability they can have is scapular elevation and internal rotation. The second pattern you can see is anterior subluxation, and that's with the head of the humerus anterior to the fossa. With that, you can see increased extension and lateral flaring with trunk alignment. And then with your scapula, you can see that elevated winging. And then with the distal extremity alignment, you can see elbow flexion and pronation and supination. With anterior subluxation, you can see the movement ability. You can see shoulder elevation, internal rotation, hyperextension, and elbow flexion. With your third one, it's the superior subluxation, and that's when the head of the humerus is lodged to that fossa. With that, you can see elements with both flexion and extension with your trunk alignment. You can see internal rotation and abduction with your humeral alignment, and then the movement ability they will have is shoulder elevation, abduction, internal rotation, and elbow wrist flexion. All 3 of these have in common is they do not have the ability for external rotation, and with external rotation gives you that functional range of motion. Effects on individuals with subluxation, you can have increased potential for arthritis. You can have the continue to have instability, subluxations, and possible dislocations in that shoulder. and then you have potential for not being able to return to the same level of activity. So it's very important for patients who have subluxation to get therapy so they don't have these problems and they can get back to their same level of activity and function. With subluxation, some elevation treatments are patients should perform activities that maintain proper trunk alignment. Also, you can see shoulder supports like slings. What therapists need to remember is slings must support the scapula on the rib cage with that glenoid fossa facing upward, forward, and outward, and must compensate for a lack of support by that rotator cuff. You always want the desirable position, which is the humeral abduction, your external rotation, and elbow extension rather than have the position of your humeral adduction, internal rotation, and elbow flexion. If you have that adduction and internal rotation, you keep it very close to your body. Also, for treatment, add resistant training into treatment plans to get some strength in the muscles, and then maintain mobility of scapula and humeral head to prepare for return of function. And then provide positioning strategies, especially when patient is not involved in activities. And then keep your treatment task specific. So holding toothbrush, lock wheelchair breaks independently, so they know what they need to work on and what they want to gain from treatment. So if they're having problems holding toothbrush, focus on that. If they have problems with strength, so they can't lock the wheelchair brakes independently, then work on that as well, so they can gain that function they need, so they can be more independent as possible. So tonight, that's what I have for subluxation. It was a very interesting topic to go over, and I've learned a lot. Thank you for listening.